Hi, good evening, everyone. My name is Parminder mentioned is Gerard Tuohy. I'm the pharmacist in charge. I work at one of Valley's retail pharmacies up at the Mawa Lifestyles building up on MacArthur Boulevard. Thank you for tuning in. And like as Parminder mentioned, if there's any questions, we'll try and go over them. If not, I'll give everyone out my email and people can email me directly. So we'll go a little brief overview about migraines, kind of pathophysiology, some of the current treatments, some of the treatments beforehand, and where this disease state is going. So migraine prevalence. Migraines actually affect more than 1 billion people each year, and it affects 1 in 6 people in the United States. About half the people who start off with migraines, usually with children, usually is more common in prepubescent boys, but as soon as girls start to mature, you notice that the migraine prevalence actually increases in females. There's about a 3-to-1 ratio between women to men, where 18% of women come down or develop migraines, where 6% of men have migraines. It's the leading cause of disability worldwide in women under the age of 50, and it's actually considered the sixth most disabling disease worldwide. And migraines cost the US economy close to $27 billion annually. Now, half of that is medications, doctor's appointments, doctor's visits, ER visits, but half that cost is actually attributable to loss of productivity at work. When patients develop a migraine headache, they may have to leave work, they may not go into work, they may not be as productive at work, they may have to seek a dark room to need to lay down till their migraine goes away. So are migraines being successfully treated? Well, that depends on who you ask, because patients who know they have migraines generally know what works for them. They take their medications pretty regularly. They know when their symptoms arise, but a lot of people don't even know that they have migraines. It's actually estimated that 50% of cases may remain undiagnosed or misdiagnosed, and that up to a third of migraine sufferers do not even see a physician. So they may be treating their migraines with over-the-counter medications such as aspirin, Aleve, Excedrin, something along those lines. And so they may not even receive the correct diagnosis, or they may not even be diagnosed at all as a migraine sufferer. And patients who have migraines, they actually may be diagnosed with a different type of headache. There's different types such as a cluster headache, a tension headache, a sinus headache, as those symptoms may overlap between the different types of headaches. A cluster headache is usually where a patient has a lot of headaches over a period of time. It could be weeks to months, and then they may go months to years without having it. A tension headache is your run-of-the-mill headache you might get from overwork, stress. And then sinus headaches, people may actually be diagnosed with a sinus infection and be treated with an antibiotic, and their symptoms go away, but that actually may be the migraine going away. And in one survey, 40% of patients who met the diagnosis for migraine were diagnosed with a sinus headache. So that even tells you that the symptoms might overlap and the patients may actually be misdiagnosed or not being treated properly. The migraine pathology. So it's not completely understood. There's different theories that exist. We do know there are some people who think there's something called what they would say like a migraine generator in the brain. Something's happening in the brain and then it's affecting different parts of the brain. And that's why a migraine headache not only has pain, but there's other associated symptoms with the migraine. And so we think that the migraine headache is most likely due to disturbances affecting the brain and the blood vessels around the brain. And I mentioned here different parts of the brain which are affected by the migraine headache. Not everyone will get all these symptoms, but they'll often accompany the migraine headache. So you can see the trigeminal vascular system disturbance. That's what's responsible for the pain, real severe, sharp pain. And then there's disturbance of the occipital nerve. That's what causes the aching, burning, and throbbing. The throbbing pain is very common in the migraine headache. That's what we really use to differentiate between like a tension headache, which might be dull. A migraine headache is just pounding away at you. And then there's the activation of ophthalmic branches, which can cause visual disturbances, photophobia. So patients who have a migraine headache, like I mentioned before, may have to go into a dark room, lights, bright. Even looking at a sheet of paper, a white sheet of paper might actually cause their migraine to get worse. And then they also may develop phonophobia, meaning that somebody who's talking normally might sound like they're shouting. Something that's a normal sound may sound like fireworks going off in their brain. And then I mentioned the aura here. I'm going to get into that on the next slide, but some patients are actually, only about 30% of patients develop what they call an aura. And an aura comes right before the migraine headache starts. So patients who actually have an aura will can actually start treatment right away, or at least they know that a migraine is more than likely coming. The chemoreceptor trigger zone, which is also affected by what you use like chemotherapy meds to treat cancers, which causes emesis or nausea and vomiting, is also affected. So patients who have migraines may not only have just the pain, but they may be throwing up, feel nauseous, and vomiting as well. And is there a genetic effect? There definitely is. We don't know what it is, but the family history is the biggest risk factor for migraines. If you have one parent who has migraines, you have a 50% chance of developing migraines. Whereas if you have both parents, there's a 75% chance of developing migraines in your lifetime. So this is the classic migraine symptoms. Some patients, you don't have to have all of them, but these are more than likely the common symptoms that patients experience. And like I said, you don't have to have all of them, but you have to have at least 3 to be diagnosed with a migraine. So you have to have severe pain, and I put it's easy to differentiate from a tension headache. Now that's for somebody who actually gets both tension and migraine headaches. There's that throbbing, pulsating pain. It's not a dull ache. It's a pounding, a constant pounding in the head. Unilateral, meaning that it starts on one side, either starts on the left or the right, and will usually stay there. But the longer the migraine progresses, or the more time that it takes to actually control the migraine, it could affect both sides of the brain. So it may start off as unilateral, but it might shift from left to right or right to left. And patients who experience migraines might get them on both sides as well, meaning that the migraine may start on the left side and may start on the right side. There's no telling which way it may start. The aura, like I mentioned before, 30% of migraine patients develop what they call an aura. And what that is they know that something's going on. They know that the migraine is coming. It could be visual. They may see spots. They may be bright lights. They may see dots. It could be sensory. It could be like all of a sudden they smell something. Something smells stronger. There's a bad smell. Or a neurological effect. Some people get like a tingling in their fingers, or they feel like a tingling across their brain, knowing that the headache is coming. And 30, like I said, 30%, maybe 20 to 30% of patients develop an aura. And those patients are fortunate in that they know the migraine is coming, so they can start treating with medication right away. Because when you treat a migraine headache, you really want to nip it in the bud. You don't want it to develop, or you don't want it to progress, because that whole cascade of pain, it's affecting throughout the brain, and it's just going to, like I said, could go from one side to the other side. So you really want to stop it or abort it right at the beginning. Migraine headaches, the length of the headache is 4 to 72 hours. Now, that may not be all constant pain. A lot of people, when they have a migraine headache, when it's over, they feel very fatigued. And we'll get into that with patients who have chronic migraine, because they might be considered a headache day, even though they don't have the headache, but they're dealing with the effects of the migraine headache. Nausea and vomiting, like I mentioned before, a lot of patients who have migraines, some people might actually develop nausea and vomiting as one of their first symptoms before the pain comes on. And it's also very disabling. Each person is different. Pain is subjective. So I can't say each person's level of pain or tolerance to pain and what they consider a response to their medication could be different. But for most patients, the migraine is usually disabling, require them to either go home from work, never go into work in the first place, or just basically take it easy as best they can. So the migraine diagnosis. This was from the American Headache Society, and patient has to have at least 5 episodes per lifetime. The headache has to last, like I mentioned before, between 4 to 72 hours, and they must have 2 of the following pain. Moderate to severe pain, like we mentioned. Unilateral, starts on one side, but it may progress to bilateral. That pulsating or throbbing pain, not a dull ache. It's something that just does not go away. You can't like really work through it. And aggravated by or causing avoidance of normal physical activity. That could be work, exercise, something you seek pleasure in, where the migraine just totally destroys your plans. And they should also present with at least one of the following: nausea or vomiting, and phonophobia or photophobia. Now, if patients, like I mentioned, develop the aura, they only need 2 of these episodes to be diagnosed with a migraine headache. So if the patient has an aura, same qualifications to diagnose the migraine, except they only just need 2 episodes. And we also have what they call chronic migraine sufferers. And those are patients who they present with what they call greater than or equal to 15 monthly headache days. They may not be having symptoms those days, but they might be feeling fatigue. They might be feeling the after effects of a migraine. Their migraine might not have fully gone away, but they're still dealing with it. So basically, essentially half of their month is consumed with a migraine some way or another, whether it's they're actually having symptoms of it or they're just dealing with the after effects or feel like a migraine is coming on. And they have to have greater than 8 days of symptoms. Those are the symptoms, like I mentioned, the pain, the nausea, and vomiting. But a lot of patients, when you see the migraine, it can last up to 3 days. So patients may get relief within 24 to 48 hours, but it might take them a day or two to recover because it was such a whopper of a headache. Imaging is not recommended to make a diagnosis of migraine. Some doctors or some physicians might not feel comfortable with migraine and might send off to a neurologist. But an MRI or CT scan is not required to diagnose a migraine, but it can rule out a migraine. For example, if somebody has another condition, for example, a brain tumor, somebody has cancer, someone has an autoimmune disorder that's causing inflammation in the brain, or if there's a change in intracranial pressure. So if somebody has like meningitis or something like that, although a meningitis patient would usually present with a fever as well. But it's that kind of pain that they're experiencing with the migraine that might be considered or might be thought of as another condition. So the MIDAS assessment the MIDAS score is basically paints the picture of what the migraine patient is going through. It's a pretty simple test to fill out. It basically asks you a few questions and it goes over the impact that migraines have had over the past 3 months. And like I mentioned here, it can help guide treatment and assess efficacy of the treatment regimens. So patients will score this questionnaire and they'll score from like 0 to 4 or 1 to 4, depending on the score, where they have little or no disability, mild disability. And basically they'll start with a score. And like it says here, the scores can range from 0, where they have little or infrequent disability, which is very rare, to greater than 21, which is severe disability. So it kind of lets you know if you're going to be starting a treatment. Well, let's see, compared to this 3 months, the past 3 months, let's see how the next 3 months go. We manage our migraines. So if our score goes down, then we're doing the right thing. If not, then we might have to move on to a different treatment. So this is something that patients can take. It's pretty simple. You fill it out online. Sorry, the picture looks a little blurry because I kind of copied and pasted it and I tried to blow it up. But like I said, it more or less, not really only the patient, but for the physician as well, kind of lets you know how disabling these migraines are and what can we do to improve the patient's response to them. So the treatment of migraine headaches. The American Headache Society updated their guidelines in 2018, and basically these are the key points that they've said when treating a migraine. That the plan should be individualized or patient-specific, meaning that if I have a migraine, my sister has a migraine, my wife has a migraine, you might all take the same thing, or you might, if you see the same physician, but your treatment plan should be individualized to you, not just a generic approach to treating the migraines. Because each person's migraine is going to not only respond differently, but patients' ability to function when they get their migraine is also going to be different. Some patients can go through the workday, more than likely not, but you want to make sure that the treatment plan is specific to the patient, taking into account what the patient likes to take in terms of medications, different formulations. Does somebody want an oral tablet? They want a nasal spray? And also, you're going to have to think of what other conditions they may have. You want to achieve rapid relief of pain and symptoms with minimal need for repeat dosing, meaning that you want to start the medication as soon as possible. Hopefully, if you're lucky enough to get the aura, you would take the medication then. If not, start it as soon as you get the migraine. And one of the problems with some of the therapies that are out there now is that they're very expensive. And this started back even with the triptans, which we'll get into, which came out in the early 90s, where they came in packages of 9 or 6, and a lot of insurances would only cover 9 or 6 per month. So patients were very hesitant to use them. They were really kind of saving them for the big headaches, or they didn't want to use them. Whereas the triptans now are pretty much generic and they're relatively cheap, but some insurances still will only limit how many patients can use per month, per 2 months, 3 months supply. And so patients, I think, in that mindset are very hesitant to use them, where the treatment now or the treatment guideline recommends that you start them right away because you want to get pain relief and eventually get back to your normal daily life. Relieve other symptoms in addition to pain. So that's if somebody's experiencing nausea and vomiting. Somebody might have a headache that lasts 2 to 4 hours, 4 to 6 hours, that goes away. But if they're nauseous for 24 to 48 hours, they're still disabled and really can't get back to work. Most important thing is restore the patient's ability to function. We want to get them, stop the migraine, get them back to their daily activities. And then discuss the option of prophylactic therapy to all migraine patients. So some patients may only have 1 or 2 migraines a year. Some may have 1 to 2 a week. I mean, it depends. So it depends on what patients, how their ability to handle a migraine or what their threshold is for determining that they want to like cut down on the migraines. I mean, obviously everybody would like to cut down on their migraines, but some people will just kind of grin and bear it, whereas other people will try and take more like a prophylactic approach. And then implement some lifestyle changes, which we'll get into at the end. Some lifestyle changes that can be done in terms of like exercise and diet, so that way patients will have less migraines as well. So acute migraine therapy originally was recommended. This is for patients who have like a mild to moderate migraine. And again, this is going to be patient specific. They recommend, and this may be also the patient that we mentioned before that doesn't even know they have migraines, but they feel like they use an over-the-counter product, whether it's aspirin, ibuprofen, naproxen. Any of the NSAIDs can be used to treat a migraine, but aspirin, ibuprofen, and naproxen are the ones that have been the most studied. And then I also mentioned ketorolac on here. You'll see that comes as an intramuscular injection or by a nasal spray. It does come as a tablet, but you would not use that as for migraines because a lot of patients can get upset stomach or GI bleeding with that. The intramuscular injection is usually something that's given like in an emergency room or giving at a doctor's office. But you also have to consider adverse effects and precautions that come with these drugs. Patients can get upset stomach from them, esophagitis, and you also have to avoid in patients with renal disease. And even elderly patients may be predisposed to developing like not renal failure, but an acute renal issue where ibuprofen or aspirin, if they take continuously for 3 to 4 days, could cause issues. Like I said, this is recommended in patients with mild to moderate migraine and are still able to function, but they've kind of become not as popular anymore, although you will still see like the over-the-counter, such as Excedrin migraine, which is a combination of 3 products, which we really don't recommend as much because patients with an Excedrin migraine, there's 3 products, acetaminophen, aspirin, and caffeine. The caffeine can actually cause what they call like a rebound headache. So it might dull the headache, but it really doesn't abort the headache. Sorry. Triptans. So this is basically the gold standard, and this is generally what's recommended first line for patients who develop migraines. First agent was sumatriptan, brand name was Imitrex. It was approved in 1991, and it's still used today, and it's probably the most popular triptan that I dispense in the pharmacy that I work. Again, with the triptans, you want to start as soon as possible to prevent the cascade of pain and achieve pain relief. They work on serotonin in the brain, and it blocks multiple receptors in the brain. So not only, oh, sorry about that. Sorry. Not only does it help relieve the pain, but it also works in that chemoreceptor trigger zone, so it helps relieve the nauseous and vomiting that a patient may experience with a migraine headache. They're available in different formulations for patients experiencing severe nausea and vomiting. So not only do they come as tablets, they also come as an oral disintegrating tablet. Sumatriptan comes as an injection, which was actually the first way it was the first triptan that came to market in 1981. Imitrex actually originally came as an injection. Not used as much today, but we still have some patients who use it because they know it works for them. And that's a common thing with migraine patients. They find out what works for them, and usually they'll stick with it. But again, patience is required as patients may respond differently to agents in the same class. These all work the same way. They work on serotonin receptors in the brain. Like I said, they'll help with the pain, the throbbing, they'll help with the nausea and vomiting. But some patients may find one works better than the other. Again, pain is subjective. It's just like the NSAIDs before. Someone might find that naproxen works better than ibuprofen. Same thing with this class. If one doesn't work, they'll recommend you trial it and try another one before discontinuing the class completely. And there's a whole bunch of different ones. There's 7. So you might have to knock off 2 or 3 or 4 before you find one that works before moving on to another class. And the nice thing about this class is that they have similar onset and dosing frequencies when taken differently. When taking different triptans. So usually with these, you start as soon as you get the migraine headache, and then you repeat within 2 hours. And that goes across almost all, and I'll go on to the next page, which shows you the different triptans that are commercially available. And like I said, you start them, and then if you need another dose within 2 hours, you take that other dose within 2 hours, but then you're maxed off at 2 a day. And they also do not like that you switch. So you can't say take sumatriptan, when you feel the headache and then switch to another triptan 2 hours later. You would have to really wait 24 hours before you're switching different triptans. And so these are the commercially available triptans. I put the brand name in parentheses because people may be more familiar with them. These are all available generic now. But like I mentioned before, when these first came out on the market, these medications were very expensive. Imitrex was about $25 per pill. The generic is like not pennies, but it's a fraction of that. But again, some of these insurances still have that in their head where they'll require patients will only get like 9 per month or 18 per month, and patients are very hesitant to use them, which is a shame because, like I said, we want to start them right away. Imitrex comes as not only a tablet, but also comes as a nasal spray, which is a nice option. Not only for patients who have nausea and vomiting, but for some children, the nasal spray is approved for them if they don't like taking a tablet. The zolmitriptan, the same thing as well, comes as tablets. It comes as an ODT, as an oral disintegrating tablet, meaning that you put it on the tongue and it should dissolve within a minute or two. So that's nice because you don't want to take a tablet and then if you're nauseous, throw it up and get no benefit from it. So the nasal spray, the injections, and the oral disintegrating tablets are nice options for patients who experience nausea and vomiting with their migraines. And then there's the rizatriptan, which also comes as a tablet, an oral disintegrating tablet. I could list them there, but you can see them there. The one on the bottom, the Emerge, the naratriptan, that one's a little different in that that takes a little longer to work. Most of these triptans have data. Originally, when they did their trials, they were doing pain relief, and pain relief they would measure at 30 minutes. Now they measure pain free. So there's a difference between pain relief and pain free. But most of these have onset data within 30 minutes that differentiates from placebo quite considerably. The naratriptan, the Emerge, takes a little bit longer to work. So that one takes about an hour before it kicks in, but you don't have to dose it as often. And instead of repeating in 2 hours, you repeat that one within 4 hours. But I have some patients that take naratriptan because they know it works for them. So even though it takes a little bit longer to kick in, they may not need to redose. Then one tablet might work for them. See, I mentioned there the directions. Triptan should not be used for more than 2 days per week. Like I said, mixing triptans within 24 hours is not recommended. The only one that you can really do that with is sumatriptan. You are allowed to use the tablet and the injectable within the same day, but it would only be one of each, and that's it. These work, like I said, they work on serotonin, but they do cause some vasoconstriction. So you want to be careful. It's transient, but you do want to be careful in patients who have coronary artery disease, stroke, or peripheral vascular disease because there is constriction of the blood vessels in the brain. The GPANs. So this is a relatively newer class of drugs. They're very, very expensive, and they do have an unmet need. They may not be as effective as the triptans per se. The triptans will also probably be required on most insurances because they're generic. The guideline recommends that the patients have a contraindication to a triptan, or you've tried 2 other triptans and they've been ineffective, then you may want to switch to this class. These drugs have been out for about 5 or 6 years now, but these are very, very expensive. The insurances will often require prior authorization with them. The Nurtec and Ubrelvy tablets are over $100 per pill. The Nurtec comes in a pack of 8 and it's about $900. The Ubrelvy comes in a pack of 10. It's over $1,100. So it's about $110 per pill. And the nasal spray, which just got approved earlier this year from Pfizer, comes in a pack of 6. And that's you use one nasal spray and you may repeat within 2 hours. These have similar dosing as the other triptans, where you start them and you repeat within 2 hours. But again, it could cost a lot of money. And the Zavspret, the nasal spray, comes in a pack of 6. And that's about $1,400 per 6 nasal sprays. So you can understand why people are hesitant to use them, especially if they're paying out of pocket for them because they're very costly. Prophylactic or preventive treatments. So you have patients, what we just went over was patients who have an acute migraine, but they do have medications that are used to prophylax against migraine medications. And this should be a shared decision between the patient and the prescriber. And it should be offered to all migraine patients. Some patients will find migraines very disabling, and they might not have that many, but they don't want to go through another one. And anything that they can do to prevent that, they're willing to do. Other patients, they know what works for them. They have to lie down, or I don't know. I don't suffer from migraine, so I can't really paint the patient picture that much. I know a lot of people who do, but some people just basically go through it. They take the medication and they'll just treat it episodically. But it should be offered to all migraine patients, or at least know that there's an option out there. And also, patients who take acute medications like these triptans, it could lead to triggering a headache or rebound headache. That's more common, not really with the triptans and the GPANs, but it's more common with the products that contain caffeine. So like I said earlier, like the Excedrin migraine, caffeine can cause a rebound headache. caffeine, some patients will use caffeine to help treat their headache. When I was in school years ago, I did a rotation at a migraine clinic in the city, and we had a patient who walked in with a 3-liter bottle of Pepsi, and that was her crutch for the day. That she would drink that Pepsi, and because of the caffeine didn't get rid of the headache, it kind of dulled it, but it was a vicious cycle where she would just keep having that, and that was what she drank every day. She never got rid of the headaches, but it kind of dulled it and made it more tolerable. But like I said, it was a vicious cycle. Um, Acute medication should be limited to using less than 2 days a week. So if you're using like those triptans, ideally you don't want to use them more than 2 days a week. And patients should have realistic expectations when starting. So if you start a prophylactic medication, success isn't defined as no headaches ever. Actually, 50% reduction in number of days with headaches, significant decrease in attack duration or severity, improved response to acute treatment, and decreased disability and improved quality of life is success. So if you have a patient who gets 5 to 6 migraines a month, going down to 2 or 3 is actually very considered a success. So it's not going to be an all or nothing approach. Just actually limiting the amount of migraine headaches is considered our goal, and 50% is what we're trying to reduce. And so we might go from 5 or 6 to 2 or 3, and then eventually maybe get down to 1. But it's going to be very hard to get down to 0. Again, preventative treatments, they should be started at low doses and titrate accordingly based on patient response and tolerability. Basically, there's different medications that use for prophylaxis. I have them there on my last bullet point. There's different anti-epileptics, antihypertensives, antidepressants. I could fill up the whole lecture just going over them, but you have to consider other patients' conditions as well. For example, there's an anti-epileptic called topiramate, which is commonly used to prophylax against migraines, but women of childbearing age should avoid it because it can cause birth defects. Some antihypertensive effects can also cause some dizziness, headache, pedal edema, and antidepressants might make people drowsy, might make people dry mouth. So you have to balance the good with the bad when you're choosing a different agent. Treatment should be given for at least 8 weeks before assessing efficacy. So if someone starts preventative treatment, they should try for about 8 weeks. If they notice no response, then they should switch to a different agent. But if there's some response, and that would be where that mitis, or even just patients keeping a daily migraine log, then they might be able to notice that they're getting some benefit. If they notice some benefit, they should continue taking for at least 6 months, maybe even 12 months, but they do have to be reassessed, see how drug tolerability is going, and also see if it's working to prevent their migraines. And so some of these are the ones that you see advertised on TV. These preventative treatments are injectable medications, and these work really well, but they, again, are very expensive. They're what they call monoclonal antibodies. They target CGRP, which is different, which is in the brain. It's actually in the ganglion. And what happens there is CGRP can cause inflammation and can touch along those blood vessels and affect different areas of the brain. So by that, this reduces inflammation in the brain. So there's, like I said, these are very expensive medications. They work for most people, not everyone. But again, a lot of insurances might require you to try something else before. I have a picture there of Aimovig. 1 pen of Aimovig, which is just dosed once a month, is about $600. So again, insurance, you might get some pushback from insurance. They're really pretty well tolerated. Ingestion site reactions, because it's a sub-Q injection just once a month, you have to rotate the site, is the most common side effect. So you might see some skin rash, but that might actually be common. None of these agents require dose escalation, although Aimovig, the picture I have here, comes 2 different strengths, and this will all be on the next slide as well. But you can start off with 1 dose, and you don't have to titrate up like some of the oral medications that you might be using. They can also be used with some oral agents. So if you might actually be taking a couple of medications to prophylax against a migraine, but usually when they jump to something of this class, they usually will discontinue the oral. And like I mentioned, it's convenient dosing, but these medications are expensive. They offer once a month. Some of them offer once every 3 months. One's actually available as an intravenous infusion. And I'll show that on the next slide. So these are the 4 common actually, there's 3 that are injectable. One is considered an IV. I put the brand name because you might see commercials for them. The Aimovig, Emgality, and Ajovy. These have all been around for about 4 to 5 years now. They're dosed once a month. And like I said, we still will use the same judgment in terms of success. It's not going to be a zero migraines, or you're not going to have migraines anymore. But if you're able to reduce your migraines by about 50%, that's considered the goal here. And you may try one of these and fail. That's fine. There's other options available to you. Like I said, most patients will try, give it about 8 weeks, give it a month or so. But some patients with these will find that they work a lot quicker. The other oral agents might take a few weeks or months before you notice effect. These you might actually notice an effect within a few days, especially for patients who get a lot of migraines. There's the Vyepti there, but that has to be given intravenous. So that's going to be given in an infusion center, and that's given every 3 months. Using patients with a MIDAS score greater than 11. The MIDAS score we mentioned earlier was the disability score. So these patients are patients who are pretty disabled from their migraines. And you can consider these when a patient has an adequate response to Botox, that's Botox there, for chronic migraine. And we'll go into Botox in the next page. Yeah. So Botox is kind of given to patients who have chronic migraine and basically have failed others therapies. It's only indicated for chronic migraine prophylaxis. So this is the patients that we mentioned earlier that have half of their month is dealing with what they call a migraine headache day, and they have about 8 days where they have 8 days a month where they have symptoms. It's only indicated for chronic migraine. I put the dosing here because I actually do have a few patients that are on this. They go to specialists. And that's another thing that you have to do. If someone's going to get this Botox injection, obviously, they have to be seen by somebody who's certified by the company. And if you go on to Botox's website, you can type in, just like any other website, you can punch in the zip code and search within like 10 miles. I actually punched in 07430 when I was doing this presentation and typed within 10 miles, which was was the lowest or the smallest radius. I think there's about 6 or 7 physicians who are licensed to administer Botox in this area, including North New Jersey, and it goes into Rockland County as well. I put the dosing here because basically it's 31 injection sites, little needles and into the muscle, dosed at 155 units, 7 specific areas of the head and neck. There's 31 injection sites, equal number of injections to the right and left side. So there's 15 on the left side and 15 on the right side. And then there's one right above the nose or right between the eyebrows. That's the 31st injection. It is pretty well tolerated. Most side effects occur during the first week and are transient. So this is an intramuscular injection. So there is the potential for like droopy eyelids, muscle pain, or weakness, but that usually goes away, like I mentioned, in the first week. And this is administered every 12 weeks. So I have 3 patients that use this, and like I said, they go to specialists for their migraine headaches. So they basically run the gamut. They've tried everything else, and this seems to work for them for their chronic migraines. But this is something that obviously has to be discussed with a licensed professional trained in administering this, because you don't want to fool around with something like this. So vitamins and supplements. This seems to be a common question or common whenever I do any of these presentations, because there's a lot of literature out there on vitamins and supplements for every disease state. The one that probably has the most merit among these are probably magnesium and vitamin D. And feverfew, the data is hit or miss. There's also mentioned the vitamin B. So a lot of people might take a B complex because vitamin B's might help protect the nerves. But patients who have migraines seem to have lower levels of magnesium and vitamin D. So again, this would be something you'd want to get tested before you actually go out on your own. Vitamin D is a fat-soluble vitamin, so it could lead to vitamin D toxicity. And like I said, maybe people will take like 400 to 1,000 units a day of vitamin D, but really would have to get your vitamin D level checked. Feverfew has also been shown to, in small studies, help with migraine patients. Doesn't really help with the pain itself, but might be used as a prophylactic agent. And melatonin, I can see the point of using melatonin, because if somebody doesn't get a good night's sleep or good rest, that's actually one of the risk factors for migraines. And then there's lifestyle modifications as well. These are little things that might help patients who have migraines. They have to maintain regular schedules for meals and sleeping. As mentioned before, that's why people take melatonin to help with their sleeping. So because if patients don't have like a regular sleep schedule or their meal schedule is thrown off, that can lead to a migraine, and dehydration can lead to migraines. They should keep a diary of headaches to notice different patterns. So they should keep a track of their migraines and notice that, hey, maybe days where it's stressful, or maybe days where I got overloaded at work, or there were too many things going on. That's what precipitated the migraine headache. Maybe poor diet. I was busy at work all day. I didn't get a chance to eat lunch or dinner, and now I'm going to eat dinner at 8:30 at night. So that could also bring on a migraine. Daily aerobic activity is actually shown to reduce the duration, frequency, and severity of headaches. And it doesn't require a lot. Actually, they recommend about 30 to 60 minutes, 3 times a week, has been shown to actually reduce the frequency and severity of headaches. So it could be brisk walking, doesn't have to be, running a marathon, but getting out and getting brisk exercise for 30 to 60 minutes, aerobic exercise, excuse me. So whether that be walking, brisk walking, biking, or swimming. Avoid drinks with caffeine because that can cause rebound headache. As I mentioned before, caffeine can kind of dull the headache, but it also causes rebound headache. So you're not really aborting the headache, you're just making it dull, and then it comes back worse. So it's like not come back worse, but it just comes back. Avoid bright lights and work in dim lit areas. Again, patients might be what they said that phonophobia, bright lights, even looking at a piece of paper might help bring on a migraine because just the reflection on a white piece of paper. And lastly, they should apply a cold compress to the head or neck when a debilitating migraine strikes. It could be a frozen bag of vegetables, an ice pack, something, even a cold bottle of soda, something, a cold compress to the head or neck. Leave it on for about 10 to 15 minutes. It won't get rid of the headache, but it might actually dull the headache, so it might make it a bit more tolerable. So what should the migraine patient continually assess? Do I have migraines or another type of headache? More than likely, the migraine patient will know if they have migraines or if it's a tension headache, sinus headache, cluster. Well, they might not know a sinus headache, but we've noticed that patients who have sinus headaches will get treated with a will get treated with an antibiotic for like sinus infection. And so the patient might start an antibiotic and they start to feel better within 3 to 4 days. Well, that may be the migraine even actually wearing off because migraines usually last 4 to 72 hours. What lifestyle modifications can I make? Whether that be simple as making sure that you're hydrated, try and do some exercise, keep a diary at home to try and monitor your headaches, what's causing them. Is there a certain, can you notice something, kind of play detective or investigator with the past migraines? Is there anything that you noticed in the past? Is it something I ate, something was a very stressful time at work? Are there certain foods I should avoid? What is my plan when I feel a migraine attack coming on? Like I said before, these medications, when they first came out, especially the triptans, people were hesitant to take them. They wanted to save them till it might be too late. The theory now is you got to take it right away, started. And then you have patients that, they should have it with them at all times because they never know when a migraine attack may have, keep 1 or 2 in the car or keep it in your wallet or keep it someplace, your work bag, something, because if you're at work and a migraine comes on and you're out of luck, I mean, the other thing you have to do is go home, but maybe you can take it and sit down for a while and maybe it won't be as bad. Or, if you take these medications, like I mentioned before, when they were first studied, these medications have onset data within 30 minutes. So you might be able to resume going back to work or, getting your time, easing your way back into things. What medications work for me? Are there side effects of drug interactions I should be concerned about? A lot of these medications are pretty well tolerated. Some of them may make you drowsy, but also a migraine itself might make you drowsy, so that might not be the medication itself. Drug interactions should be concerned about. Really not that many with the triptans and the gepants, but if you're taking a prophylactic medication, is there something I should be concerned about? If I'm taking another medication, will it interact with another medication? And what are my migraine triggers? Is it stress? Is it work? Is it dehydration? Is it something that, you know that a migraine's coming on and you should really try and avoid it in the first place? These are my references. And I'll open it up to Parminder to handle the question aspect of it.
That was a fantastic presentation, very comprehensive. Thanks, Gerard.
Thank you. Sorry if I went too fast.
Oh, no, that's good.
Okay.
There are a few questions. You may have addressed a few of them, but I'm just going to go ahead and pose them. So actually, one of the questions is, can birth control give you a migraine?
Okay, so there's the potential. This is going to sound strange. We mentioned that prepubescent boys are more likely to migraines, and then as teenage girls, they get their period, and then it becomes more a 3-to-1 ratio women to men have migraines. So we have patients that hormonal imbalance can cause migraine headaches. That being said, I have patients that actually use an oral contraceptive to help treat their migraines. So I don't want to talk like I'm talking out of both sides of my mouth, but there is the potential that the birth control could cause migraine, but like I said, there's also different birth control medications out there and I know two patients off the top of my head that actually use a birth control continuously. They're not using it for contraceptive use, but they use it to prevent their migraines.
Oh, that's very interesting.
Yeah.
Um, Another question. This person says Excedrin works extremely well for her, or him.
Okay.
I'm concerned, though, about the negative impact of the acetaminophen portion on my liver.
Okay.
What other product would be a close second to the wonderful results of Excedrin with less side effects?
Okay. So if Excedrin works for you, that's great. I would continue to use it, to be honest with you. I know I kind of bashed it in this only because it mentions there's a chance for rebound headache. But if you, and you know what, the guidelines don't even really recommend aspirin or acetaminophen or caffeine anymore. There's actually a prescription drug, Fioricet and Fiorinal, and they actually got their name from Montefiore in the city because that's where the drug studies were conducted and that's where the research was done. But acetaminophen and caffeine more likely can cause a rebound headache. But if they're only using it periodically, not using like, because we have patients that use acetaminophen, unfortunately, all the time. But if they're only using it when they get a headache, as long as they don't exceed 3,000 milligrams a day and they're using it like an acute time period, I assume like 2 to 3 days, they should be fine.
Okay. So it's
Yeah.
not, you don't want them, so it's not something you should do long term, though. It's just something
Yeah, it's not
like,
something you would do
right.
long term. So I'd be curious, like how many migraines do they get a month? I mean, do they use
Yeah.
it all the, if they get, a few migraine, if they're a chronic migraine sufferer, then it's probably not really doing that much. But they said it works very effective for them. So I'm assuming they're using it like acutely and it gets rid of the headache. So if it gets rid of the headache in the first day or two, I wouldn't be too concerned about the Tylenol component, to be honest with you. Unless, and this is completely, unless they have other conditions where they have like, fatty liver, cirrhosis, or something like
Mhm.
that, or an alcoholic or something where the liver has been damaged, because Tylenol does get filtered to the liver. And years ago, and this was something that happened with the opioid crisis, a lot of the opioids had high components of acetaminophen or Tylenol. Some of them had 750 milligrams per tablet. People were taking 6 to 8 tablets a day. And originally, the FDA recommendation was that patients take less than 4,000 milligrams a day of Tylenol, which is basically 8 500 milligram tablets. Now the recommendation is brought down to, well, not now, it's been for about 14 years, is recommended that they take less than 3,000 milligrams a day of Tylenol. So that's 3 grams. And so if they're taking a couple of Excedrin migraine 2 every 6 hours or so, and they're only using it short term, I wouldn't be too concerned, to be honest with you.
Great. I see someone had raised their hand. If you wouldn't mind just putting your question or comment in the Q&A, thank you. Next question. Are there certain foods that can trigger a migraine?
Certain drugs that can say, yeah, I mean, there's like certain cheeses that can cause migraine headaches, but that's really about it. I mean, there isn't really any foods you should avoid. I wouldn't really avoid a certain food because, like I said, you don't want to get dehydrated. And most of the times when we think of dehydration, we think of like, fluids, but also meals as well. You could dehydrate. And then also you could also have low blood sugar, which also can actually almost kind of bring on a migraine headache as well. But there's certain aged cheeses, like cheeses that contain like tyramine, that those can like potentially cause migraine headaches, but it's really about it.
Okay. And then will menopause make migraines worse?
What they've noticed is that patients who actually get older, that the migraines actually get more tolerable. So, and most of the treatments with migraines, most patients who develop migraines, it's usually young women. And like I put that slide up, it's the leading cause of disability in women under the age of 50.
Mm,
So what I've noticed, and this is, I'm not a woman, but is that patients who have migraines, they seem to become more tolerable and menopause really shouldn't bring them on or make them worse. There is, like I said, there's hormonal changes, but most of the patients who I have who have migraines are, like I said, are mainly, or that find the most debilitating are basically young women under the age of like 30 or 40, to be honest with you. I
okay.
mean, there's always the potential. I don't want to make it seem, but patients, it seems like not that they age out, but the migraines become less impactful as they age.
Got it. Are there dietary sources of magnesium?
Yeah, I mean, you can buy magnesium in a tablet. You can buy it over the counter, Or dietary sources. I mean, you can get them in different types of vegetables, different types of proteins, and different types of meats.
Mhm.
But you could also just buy it in a tablet, like, and it's very inexpensive. They make magnesium like 400 milligram, 500 milligram tablets, and like a bottle of 100 is like $6 or $7. But you can get magnesium in different types of like leafy vegetables or different types of protein sources like chicken and meat, like red meat, but
Mhm.
don't eat too much red meat.
So the doctor recommended taking a diuretic 5 days prior to menstrual cycle to help alleviate getting a migraine. What are your thoughts?
Um, Are they taking anything else for the migraine? I mean, some people might, because some of the over-the-counter, like the Midols and stuff like that, have a diuretic in there, which is kind of for the bloating. Um, I'd be curious to see which diuretic they prescribe, to be honest with you.
Mm,
I if someone I can give you my email and we can discuss that further because I don't feel really that comfortable. And I don't know exactly what diuretic they're taking. Is it an over-the-counter like water pill or is it like a
mhm.
prescription? You know, and there's different types of diuretics
Yeah,
and different potency. So you have like loop diuretics, which are more potent, and they also work in different parts of the kidney. So that one, I'll give my email at the end, or Parminder, if you want to. You can.
sure. Um, okay, let me see. What type of doctor can you go to help with migraines and give you medication?
Well, primary care can diagnose. Probably the best one is probably either a neurologist or pain management. Most of the patients who I said, like I said, who are on the Botox, they get their Botox from like neurologists and they see like migraine. There's one that goes to New York City. There's one that goes to see a neurologist in Bergen County, and one actually goes down to Philadelphia to treat her migraines because nothing she found was working up here. That's nothing to say the area. It's just that that's the doctor she feels the most comfortable with. And so it's strange to get prescriptions sent to me from Philadelphia, and then the patient's on their way. But they go see their doctor every 12 weeks because they get their Botox injection there, and then they're on other medications as well. But most likely, it's going to be a neurologist or a pain management physician. But neurologists are basically that's their bread and butter.
Okay, and then this person said, I'm sorry, Ajovi has worked well for me for 3 years.
Okay.
Recently, it has stopped working. Do
Okay.
you think I would have any luck with any other type of monthly injection?
Yeah, I mean, they could switch. I mean, I don't want to say it's common, but there is sometimes, even with some of the other medications, you have patients that take sumatriptan or Imitrex and they've used it for 15, 20 years and then it just stops. And then they're like, oh, now does that rule out the class? No. So we've had that with patients. We had one patient who took a Jovi and it was once a month, and then they have the option that they can use it every 3 months. They take three injections at one shot. No pun intended. But they can switch to Aimovig and try and see if that works. They work similar, but just like the other medications, they might work the same, but you can't rule out the whole class. So if somebody's tried a Jovi and it's no longer working for them, then I would recommend they probably switch to Aimovig because that's the more common one. Those are the two competitors. They both work the same way. They both work. They're both monoclonal antibodies. They both work on that CGRP. So I would actually try like switching from one to the other. And that's common where I have patients who taken a Jovi either didn't work or did work and they switched to Aimovig and vice versa. And each person's response is going to be different because it's patient specific.
Okay. Are there migraine medications that offer quick relief, like under 2 hours?
Yeah, I mean, most of the medications that they've studied, like especially the triptans and the Gpans, which I mentioned, most of them have onset data within 30 minutes. So these patients start to get pain relief or actually pain complete absence of pain. So, but the whole thing is you want to take them early because, like I said, when the migraine starts, and this is where patients who have an aura have a benefit, they know the migraine more than likely, if they get an aura, more than likely the migraine is going to be coming within the next. An aura can last anywhere between 10 to 60 minutes. So if somebody gets an aura, which is only, like I said, about 20 to 30% of patients, they should start the medication right away. So they kind of have a head start. But if somebody doesn't get the aura, which is the majority of people, they should start the medication right away. And like I said, they should start to notice some relief within 30 minutes. And that's usually the dosing. How it works is you take it, and then if there's no relief or you feel like you need another dose within 2 hours, you take it, repeat the dose in 2 hours, and that's it for the day. And hopefully it'll work by then.
Okay. And this person takes Tope Max 100 milligrams every day, twice
Yep.
a day, and used Amvig and Nurtec.
Okay.
Is there any new medications that are coming out that you are aware of?
The newest one that got approved was, I'm going to go back, but they took Nurtec onto the GPAN slide. So if they take in Nurtec, they could switch to Ubrelvy, but they've been around this about the same time. And then the Zavspret, that's the new nasal spray that's available. That's from Pfizer. That got approved. Don't quote the date, but it was March of this year that it got approved, and that's commercially available as now as well. So they could try and switch to that for their acute migraine. The Aimovig, like I said, they might want to switch to the Ajovy. The Topamax, I mean, you can increase the dose if you want. It depends on the tolerability. Some people find that the Topamax makes them very fatigued, or also some people with Topamax finds it makes them very thirsty. So there's other options out there for all three, but what I would do is I probably wouldn't want to switch like the patient's complete regimen. I would probably just want to swap one out because say you get success, you don't know really what caused the success. But there are
Mhm.
other options. There's definitely other options. Nurtec, like I said, Aimovig, Ajovy. That's right. Sorry, one more. And there's Emgality as well. Emgality is not as popular, but does give patients an option. And you start with a loading dose, which I should have mentioned. You take 2 shots at the beginning, and then you take 1 shot once a month. But like I mentioned here, there's other options available, and just because they work the same way doesn't mean that if one fails that you rule out the whole class.
Okay. And then do you recommend a salt pill?
I mean, if somebody's dehydrated, maybe, but I'd rather they stay hydrated rather than taking
Mhm.
just salt for the reason of taking salt.
Okay. And then last question, I think you kind of answered this before. If you avoid a food trigger for a few years, can it cease to be a trigger, or should I just avoid these foods for life?
Um, I don't know if I can really answer that. I mean, if
Yeah.
you know that that's your trigger, I would probably try my best to avoid it. I wouldn't want to tempt the devil, if you know was something that caused in the past. Because patients who develop migraines, I mean, they deal with them. I mean, obviously, there's a lot of people in the audience who have them. I mean, they kind of know what works for them. So if it's working, or that that's a trigger, and that's why we recommend that patients keep a diary or like mark on their calendar what happened when they got the migraine. Were they at work? Were they dehydrated? Did they eat something? Was there something, it could be something, even a smell that can bring on a migraine. Is it something that they work in an area that there's fumes or something and that brings on the migraine? So, I mean, they could revisit if they want, but I can't predict how someone's going to react. If they knew that was a trigger in the past, I would probably do my best to avoid it.
Great. It I think we went through all the questions. It looks like I got through all of them. I just want to mention to everyone that I did put into the chat box, Gerard's email. If anybody has any further questions, you're welcome to email him. That's correct, right, Gerard? You're okay with that?
Yeah, no, you can definitely email me. I might not get back to you right away because I'm busy, so I don't really check my email during the workday. But yeah, no, if anybody has any questions, or you can stop in and see me. I'm here 4 days a week. So yeah, by all means, stop in.
Awesome. So at that, oh, it says, can we visit at the pharmacy? Somebody asked. So yeah, that's
Oh, absolutely, yes.
yes, great, perfect. And again, the pharmacy is at 1400 MacArthur Boulevard in Mawa. It's right there. It's the big wellness center, Valley Wellness Center is a big sign outside. Come visit Gerard. He'd be happy to talk to you.
Yep.
So at this point, I'd like to thank you so much, Gerard, for your very informative presentation this evening.